right, let's get started with hyperlipidemia and its associated pharmacotherapies. So your first pharmacobrief related to this was Alex presented to the NP clinic, follow-up related to hyperlipidemia and hypertension. You saw him before, and he basically was told to go home, watch his diet, and improve the diet because he really thought he would be able to. His diabetes was out of control as well, which was likely contributing to it. So he's coming back in. The labs are still pretty consistent with his untreated hyperlipidemia, and you are now choosing to treat, and you have talked to him about HMC-CoAce reductase inhibitors, aka statins. So now what do you need to know about this? We're going to go through this class of drug and then see if you guys had the right answer for your pharmacobriefs. And then what are the side effects? When do we need to monitor after you prescribe this class of medications? And then we will go into all of the other classes as well. So basically, this is the opportunity for you to start a statin. So what does that entail? So lipids are essential for our body's processes. We need them to make our cell membrane walls. Remember, those are bilipid membrane, so very important there. We need them for steroid hormones, cortisol, testosterone, estrogen, progesterone, so very important. A lipid is classified as any physiologic substance that is fat soluble. We're going to focus on the main things that we look at when we're talking about uncontrolled cholesterol. They are present throughout the intra and extracellular environment. They're circulating all around. They're going from the blood system, from the liver, and going basically into your cells for whatever is needed. And like I said, necessary for normal function. So what are the things that we're going to be looking at? So really these classifications: chylomicrons, very low density lipoproteins, low density lipoproteins, and high density lipoproteins. So there are two pathways of lipid synthesis. So we have an exogenous pathway when you have an endogenous pathway. This is really busy, all right? So, and there are actually many more steps involved in lipid metabolism. So we're going to take the high kind of points, and just so you have an understanding, and then see where our medications work. So the exogenous pathway is obviously we eat some fat, so we have a burger, and it comes into the dietary system, into the stomach, into the intestine. So what happens in there is that it is basically needs to be transported out of the intestinal lumen. So what happens is, as the fatty acids comes in, so that's what it's going to be, free fatty acids, circulating cholesterol, triglycerides, all of that comes in there and basically needs to be taken out of the lumen of the intestinal cells. And the way that we do that is called the chylomicrons. So the chylomicrons are basically transport molecules to get free fatty acids and the cholesterol from point A to point B. Now you can see here that there is ApoE, C11, and B48. These are the apolipoproteins. These are also very important. They kind of sit on top of the cholesterol and the chylomicrons and are involved hydrolyzing. They permit the chylomicrons to be broken down. They help with the binding and allow it into the circulation here to be kind of activated upon by lipoprotein lipase. So we have the chylomicrons, we have apolipoproteins, which are very important for transition, and then basically it gets into the capillaries, and here's where it comes into contact with lipoprotein lipase. So what happens here is it will then release the triglycerides and allow the triglycerides to go to their site of action. So they're either going to go to the adipose tissue or the muscle, used as energy. Here they're going to be stored as triglycerides. And there's a lot of steps in here. In this intestinal cell, basically the free fatty acids combine with the glycerol to form the triglyceride, right? So that's how we get the triglyceride there. And then what happens is cholesterol is in the form of cholesterol esters. That is what it's going to be turned into. And then it's hydrolyzed by this acyl coenzyme A. It's called ACAT for short, and that helps form these cholesterol esters. So it's kind of a synthesis action here that happens there. So then as that happens, they are basically assembled in the intracellular lumen of the intestine, and that's how we get the chylomicrons. So then the ApoB48, which is an apolipoprotein, permits the lipid binding to the chylomicron, and then allows for that transport out here. What it does is helps prevent premature into the circulation before the lipoprotein lipase. So we don't want premature activation of that. So what happens then is after the triglycerides are released as free fatty acids, then you have leftover remnants basically of the cholesterol. And usually this is going to be more of that cholesterol because the triglycerides get released down here. So the remnants, you can see there, ApoE again and B48 on the cell surface, help them bind over here to the remnant receptor that is on the liver. And then it basically is taken in to be able to be recycled, used for other purposes within the liver. As you can see, these are the two main reasons that we need it. So bile acids, then the cholesterol will be transported to our tissues and basically be used for steroid synthesis. So that's basically the exogenous pathway. So over here you have the endogenous pathway. Now it does start here in the liver. So what happens here is we basically have pathway of acetyl-CoA. So remember, we get acetyl-CoA basically from glucose into pyruvate, and pyruvate gets turned into acetyl-CoA through all those steps. So acetyl-CoA can also go into the Krebs cycle, produce ADP, right? Well, acetyl-CoA can also be turned into cholesterol, and that's what's going to be happening here. So acetyl-CoA combines with another acetyl-CoA to basically produce this acetyl-CoA. It's another enzyme that it's made from two acetyl-CoAs. Then what happens is it binds with another one and we form a big one named HMG-CoA. And what that stands for is hydroxymethylglutarol. CoA. See, that is where we target our statin. So then there's another couple processes, steps in here. It's converted into malonic acid, and then there's a couple other steps, and basically that creates the cholesterol. Drugs work on a big reductase in here. So there's a reductase enzyme that's called HMG-CoA reductase. And that is where statins work, but it's in that pathway. This is a very important because this reductase is rate limiting, basically is in charge of allowing how much cholesterol is synthesized. If we target this, then we basically inhibit the reductase, which is the rate limiting cholesterol synthesis. So as you can see, we have our LDL, we have our HDL, we have intermediate DL, and very LDL. So basically what happens is, this is all involved in this process. VLDL is actually the first step. Synthesis actually begins with the very low density lipoproteins from the liver. It's hydrolyzed by the lipoprotein lipase. It's reduced into remnants, and the remnants are called the intermediate density lipoprotein. So very low density lipoprotein, ApoA comes involved in it, lipoprotein lipase is also, and then we get remnants called IDL. We have protein surfaces, that's those phospholipids, the ApoA, C, and E, and those are sometimes transferred and basically taken to HDL, which tries to clear it. The other thing that happens is now the remnants, the VLDL remnants, either are cleared from the circulation, they're taken up by these receptors, or they are actually remodeled by the hepatic lipase to form LDL particles. So then after LDL, so the LDL is basically the carrying component of cholesterol through the blood system. So if you want to put basically your blood vessels, LDL is a lot more cholesterol than it is anything else. So if your LDL is elevated, then we know that your cholesterol, and this is the stuff that's going to cause the damage, because we know that you have extra LDL, you have lots of potential deposition of cholesterol in your arteries. The extrahepatic tissue that it goes to would be considered places for steroid metabolism, cell membranes, or it could be stored as ester in the esterified form. What happens is HDL is very important because it will actually try and bind some of this LDL or this cholesterol that's in the system and try to get rid of it. So that is the basic cholesterol synthesis. So when we're talking about cholesterol levels, four main types basically. We're going to look at the total cholesterol level, the LDL, the HDL, and the triglycerides. The more HDL you have, the more ability you do have to bind LDL if it's circulating in high numbers. So that's why we like high HDL numbers, because it actually goes and clears the LDL out of the circulation. Total cholesterol is just an overall barometer to see exactly how much cholesterol it is. And this can be skewed by high LDL as well as high triglyceride levels. So desirable cholesterol levels around 200, borderline high 220, 230, and then 240, 250, we classify that as high. LDL less than 150 is preferred. Now, if you have diabetes or already have cardiovascular disease, we obviously have different targets. This is a good schematic for you to picture it. So here is very high, all right? So anything greater than 190 is considered extremely high. And then we question, is there a familiar component? HDL, we love you between 40 and 60. The higher, the less risk. A major risk is if it's 40 or less, so we do love it to be, in here at least. You can increase this by certain medications, certain foods, and exercise. So then triglycerides, depending on where you look, usually 150 is where we say good, so less than 150 is preferred of the triglyceride levels. And then you can have a variance of this, very high, mild, moderate, and severe elevations of the triglycerides. Anything greater than 1,000 increases the risk of pancreatitis, acute pancreatitis. That is the kind of acute concern with elevated triglycerides by themselves, is actually pancreatitis. This is something that we work to minimize the potential presentation of it with elevated triglycerides. So here is just that kind of synopsis of everything that I just said, written out in a different schematic type of format. So when you are educating and understanding, you have to know where your dietary sources of cholesterol are coming, because you are going to be interrogating patients' diets to say, hey, you need to back off on this. Or you need to try and eat this versus that. So this all matters. So obviously when I'm talking about total cholesterol, I'm concerned more about fast food, baked goods, deep fried foods, meats, milk, kind of your animal proteins, because that's what's going to get you cholesterol. The other thing that I'm going to look at too is, where am I getting my triglyceride sources? So that's the other thing that you have to understand. So triglycerides, think carbs. Basically, that's the best thing to kind of relate where you're going to get your triglycerides, right? Makes sense. It's glycerol and fat. Commercial baked goods, we don't like that. Bread, I call them super sugars. So anything that has high fructose corn syrup, all of that's going to matter, because you have to remove it. And actually, if you have severely elevated cholesterol, the first thing you're going to do is actually do a dietary restriction. Because you have to get that source out of there. So here is the good diet versus the bad diet. Fried foods, fried chicken, hot dogs, hamburgers, soda. This is what you do not want to be eating, all right? No. This is what you want to do. So we're going to go over the cholesterol guidelines. Included here, primary prevention of atherosclerotic cardiovascular disease. Just take a look at this. It's a nice little schematic. It's talking about years, as well as then how we get our risk and what is included in that. And then here are all of those risk enhancers, and basically you need to kind of correlate it with the recommendations based on that risk. So take a look at this. It's very important. This is high yield. This one, you can see here things change with diabetes, and then understanding what the risk factor is. Okay, so that's basically what you need to know. Association of Cardiologists. So some of them will vary, but most of them are kind of on point. And as you guys are seeing, we have multiple resources. We have multiple ways that we look at things. So here we're looking at American Heart Association and American College of Cardiology. So encourage that healthy lifestyle. You need to know what it is so that you can recommend it. Consider statins for patient groups who have been shown to be beneficial. That's your data. Assess risk of toxicity in susceptible patients. So we're looking at a lot of liver issues, muscle toxicity, things like that. Then you will have to monitor for adherence. And when we talk about the non-statin agents, there is limited evidence for assistance, but sometimes we have to use them because we don't have any other options. and then initiate that statin at appropriate dose based on risk. So LDL goals, all right, but previously they were like a hard target. So you need to get your LDL below 70, or you need to get your LDL less than 100, you need to have your LDL less than 150. So now we kind of have these soft targets. In my world, we still, if you have already coronary vascular disease and diabetes, we're driving less than 70, hopefully. Softer target for no cardiovascular disease, but high risk, we're looking at 100. So diabetes changes the goals in addition to some other cardiovascular comorbidities. So those treat to target is more of a soft approach now than it was a hard approach before. So that's what that means. So here is what we look at. So you got to look at the ACVD, which is basically looking what is that patient's risk. You can see here that it's going to be, is it a moderate intensity in statin? Is it a low intensity statin? Do you need a statin right now? Or can we just watch it? You have to figure out what their risk is. And calculator, it's available pretty much for free. You just download it and then you plug in all your patient's stuff. So then you can see too that we have some age bracket. We are, under 75 or greater than 75. It changes targets as well as how intense do we have to go with the statin. Greater than 75, moderate or high intensity statin is reasonable, or continuation of the high intensity statin is reasonable. And this is for a not very high risk coronary vascular disease. And then if they're less than 75 and their goal is not been lowered on it, then we start with changing our statins. Over here, very high risk. You need to have a high intensity and maximal statin to lower it. And then you can see here we have some other options. These are the new class of drugs, PCSK9, Zetia. So I basically classified this for you so that you understand high intensity, moderate intensity, low intensity statin. High intensity statins, so these are going to be your big bang for buck. So these guys are going to lower, so you can see here LDL reduction equal to or greater than 50%. We need that amount of lowering because we have an extremely high LDL. High intensity statin is warranted. Be very careful. There are certain medications that are risky with high intensity statins because they will risk higher myalgia, rhabdo side effects. Be very careful with age greater than 80 years old, use with a fibrate, impaired renal function, and frailty and multiple comorbidities because of how strong they are. The only two that are approved for high intensity therapy are atorvastatin, which is Lipitor, and rosuvastatin, which is Crestor. And then you can see the amounts they have to qualify with to be considered a high intensity statin. When you plug in ACSVD risk factor and it tells you need a high intensity, these are your two options. Next up is moderate intensity. So these are preferred in select situations with high risk for adverse effects, and high intensity statin would be a risk. So then you can see here 30 to 49%. And then we have lower doses of atorvastatin and rosuvastatin, but then we could also use simvastatin and lovastatin. Low intensity statins are not recommended as first line. These guys are pravastatin and lovastatin. Low intensity statins may be something that you need to do in the Asian population. Asian population has a genetic predisposition to having issues with statins, so you may need to go on this end for them to start. Statins and liver metabolism. Statins and liver issues are classic and hallmark of what we have to look out for. CYP450 substrates, and I broke it down here. So 3A4, we know that 3A4 is involved in a whole bunch of medications. You can see atorva, lova, and simvastatin are on the 3A4. You're going to have the most interactions with these drugs. Your 2CP, which is pitavastatin and rosuvastatin, they are actually probably the lower drug-to-drug interactions and side effects. And then if you want to avoid CYP450 because you have so many medications on board, you choose pravastatin. But then you have to take into consideration, are you looking for a high-intensity statin because it doesn't qualify? So it would actually only be qualified as a low intensity. So it's just something you have to take into consideration when you're making your choices. So what you have to do, you should get baseline LFTs. You will intermittently pull them. There's no frequency that we measure the LFTs. If it's somebody, again, that you have high risk, then you probably would want to draw it 4 to 6 weeks after you have started. You do want to pull these baseline so that you have an idea of where you started from. The time that we're going to be pulling labs, biochemical, to be monitoring effect, you definitely want to have a baseline. A small raise of the LFTs is not something that you're going to pull as statins. Statins are very beneficial medications. You don't just pull them because you had a bump of your AST and ALT by 5 points. It needs to be greater than 3 times the upper limit normal. All right, so let's say your AST is normal range, the high end of normal is 40. So you times that by 3, so you would have to basically need an AST above 120. You should also then repeat it within a couple days. Say, hey, I need to recheck that liver. Even though they had an issue with one statin does not mean that you stop the statin class. It means that you will now try a different statin. You could go high intensity to a lower intensity one. That may work, or you can change something that works on a different pathway if there may be an issue with one of the medications that the patient's taking. You could do a dose reduction. All right, so these are all options. You could also try the alternative day therapy, which means every other day. Even if the patient does not tolerate the statin therapy, even after changing, you can do it again. And a lot of times, once you try to recommend going to a different agent, such as the expensive PCKS9s, those are thousands of dollars. You have to show failure on like 3 or 4 statins before they'll even consider doing a lot of these other medications. So just something to keep in mind. So let's take a look at one of them. My favorite is actually rosuvastatin, potent, and it just seems to work well, and I'm not on that 3A4 pathway. So this is the one that I choose over atorvastatin. But it is also a little bit more expensive. So it's on formulary, and that's why I can use it and have no problem. Liver minimally, so it's a 2C9 substrate. It does have an active metabolite, so if you have anything major on the 2C9, then you may have some interaction problems. You can see there it is excreted in the feces 90% because of where it's metabolized, as well as where are we working that HCMG CoA reductase inhibitor. It's in the liver. See there, the half-life is 19 hours. And it inhibits 3-hydroxy-3-methylglutarate coenzyme A reductase, which basically inhibits cholesterol synthesis because you're blocking that reductase enzyme. Initial dosing 10 to 20. Conservative dosing is 5 milligrams. When would you do conservative dosing? Something like an elderly patient or potentially Asian population because of that genetic predisposition of your metabolism issues. So what are the side effects? Upper respiratory side effect, the arthralgias, musculoskeletal pain, muscle spasm, myalgias, all of that stuff is what patients complain about the most on statin. Nausea is a big one too. So then over here are obviously the serious reaction. Myopathy that is problematic, that would potentially lead to some rhabdo and acute renal failure, so that's where we get concerned. And then statins also have an issue with statins can cause problems with your tendons, such as your Achilles. Basically, it reduces the thickness. Baseline monitoring. So obviously we're going to get LFTs. You're obviously going to need what your kidney function is, right? Because you need to be able to make sure you're above 30, basically renal dosing. So you should only initiate with 5 and go up to a 10 max if you have renal issues. So LFTs, kidney, that's pretty much it. Creatine kinase. Only time you're going to order this is if you do have patient reporting myalgias. Okay. So that would be more of a follow-up, not a baseline. Okay. So no CKs in the beginning. So really just LFTs and kidney, so you know exactly where you're starting from and you can dose appropriately. Just remember muscle issues and pain. And then the serious reactions are obviously rhabdo related to those muscle issues. and then that would lead to acute kidney injury. So what do you need to know before you write? So obviously liver problems, and then the thing that you also need to do is be a little bit critical thinking. If you have somebody who is drinking more than 2 alcoholic beverages per day, you would be concerned that there is underlying, possibly not known liver issues which would impair metabolism and also set you up for increased risk of myalgias. Kidney disease, obviously we talked about this, impairs clearance as well as dosing. Thyroid disorder, poorly controlled hypothyroidism can also cause problems with cholesterol and utilizing your medications. The Asian descent is related to metabolism, and you have a genetic predisposition to not do well on statins. And then 65 or older, you be very careful with the elderly population, but they're very much indicated. The other thing too, when you are worried about interactions, again, those chelating agents such as calcium, iron, magnesium, all these kinds of drugs, supplements, stuff like that, you really want to keep them away from a lot of your medications because they do inactivate. So any antacids, anything with calcium, aluminum, magnesium, any of those minerals, they need to stay away from most of your medications. So next up is nicotinic acid, which is niacin, and we use this really to focus on triglycerides mainly. So you see here, increases the rate of triglyceride removal from the plasma by increasing lipoprotein lipase activity. Believed to inhibit free fatty acid release from the adipose tissue, decreases synthesis of very low density lipoprotein and subsequently LDL, because remember, VLDL is first and then we get LDL in that process. So you can see here where it goes, but you can see the main crux of a treatment is triglycerides by 50. And then increases HDL 25 to 35%, which is what we want to do, but it only has a modest effect on LDL. The problem with niacin is its side effect, and you can see the dosing. You do have a taper program with it because you want to start slow, and you want to start usually up. Should be taken with meals. So they eat. Also going to pre-treat with an aspirin. These are the big issues. Flushing, feel like you're on fire. Patients will stop this drug, especially if you don't tell them to pre-treat. A lot of patients have many side effects related to niacin therapy. Hepatotoxicity has also been reported with it, so be cautious with it. Also, you have some contraindications: AFib, weight loss, hyperglycemia, gout, and unexplained abdominal pain. Be very careful. So metabolism, it's actually unknown. It's actually excreted in the urine, and you can see it has a quick half-life, and that's why you have to take it so often. Severe liver disease, stomach ulcer, heart disease, chest pain, gout, diabetes are reasons that we would not use niacin. So I included everything here for you, so we need to look what the fasting glucose is. I do not use niacin a lot because it does affect my diabetes. It will also interact with a lot of my hyperglycemia associated agents, so it will cause a big problem for diabetic patients. So be very cautious with that. LFTs at baseline, and then this is more frequent through monitoring. You can see here every 6 to 12 weeks times 6 months, then 6 months. Also your uric acid at baseline, and you're going to be monitoring that at intervals as well. Phosphorus if you have any hypophosphatemia risk. Platelets, if any PT or platelets if any surgery is upcoming, because it can alter that. Homocysteine levels for patients with chronic high doses. There are no renal issues with it, and then just be careful in the LFTs and hepatic disease. If you have active hepatic disease, it's contraindicated. So here is vasodilation. It may potentiate antihypertensives, flushing, transient headaches, optic neuritis. Your serious reactions are hepatotoxicity, hepatic necrosis, which could be fulminant, and PUD and arrhythmias. Next up are bile acid sequestrants. So these are Welchol is the most popular, cholestyramine, and cholestyramine. So what this does is binds bile acids in the gut, and it blocks their reabsorption, and then basically the bile acid has to be synthesized in the liver. LDL receptors are upregulated, and then we basically get more LDL taken up. and then it's actually circulating LDL, which is the bad, is decreased, reduces LDL by 15 to 30%. So we can't use bile acid sequestrants if you have very high levels of triglycerides. These are also in my line of work. I don't use them very often because most of my patients have high triglycerides. Diabetic ketoacidosis, history of bowel obstruction, and history of hypertriglyceridemia-induced pancreatitis. So let's take a look at well call. Again, baseline monitoring, LFTs, serum iron, fat-soluble vitamins periodically, and there is do not use if your triglycerides are above 300. For well call, there are no issues with renal dosing. Hepatic, there are actually no issues here. Common reactions are constipation, GI irritation, bleeding, LFT abnormalities, complete bile duct obstruction, and hypertriglyceridemia. Be very careful with any history of GI disturbances. Also, any issues with fat-soluble vitamin deficiencies, and that's why you have to check for it. Some serious reactions for well call would be esophageal obstruction, fecal impaction, intestinal impaction or obstruction, and pancreatitis. Here is another look at all of these cholesterol drugs. This was a nice schematic kind of bringing it all together. So we went over statins so far. We went over niacin, bile acid resins. We'll go over Azedia. All right, so adjunct agent is Zetia, ezetimibe. Basically, that's the only one on the market, and it basically uses in conjunction with your statins, and they make your statins work a little bit better. So mechanism of action is combines with the bile salts to block the absorption of the cholesterol in the duodenum. Leads to decreased cholesterol stores in the liver, upregulation LDL receptors, and decreased circulating LDL by that mechanism. Decreases LDL by 20 to 50%. So they're big movers. And then you're going to basically add it. If you can't get where you need to go with a statin, you'll throw Azedia on top of it, and then you usually get to target with that. So let's take a look at Azedia. It can be used alone, but they really do not prefer it. It's not recommended as monotherapy. There's really limited evidence on it doing any justice. I do have a patient who is highly myalgia laden with statins. I need to get something on him, so I do have him on monotherapy of Zetia. So when given with a statin, you do need to monitor LFTs. It may increase the risk of myositis and other statin-related effects. Actually potentiates the statin, so that's why you have to be careful with it. And it should not be given if there's moderate to severe hepatic insufficiency. Liver disease a problem, it's contraindicated in anybody who's pregnant or breastfeeding, and kidney or thyroid disease. So what do you need to know? Basically LFTs at baseline, especially if you're adding it to statin therapy. We just talked about it. There is no issues with renal, so you do not have to renally dose. And then there is child Q class B or C, avoid use. So this is pretty severe hepatic disease for B and C, so you don't have to worry about it unless it's severe. Common reactions for Zetia, again, myalgias, again, this weird upper respiratory, my diabetic meds too. I don't have any reason why they happen. Diarrhea, extremity pain, and fatigue are the big ones here. Serious would be hypersensitivity reaction. Everything we talk about always has a risk of hypersensitivity or anaphylaxis. They're chemicals, all right? Anybody can have a type 1 sensitivity reaction to anything at any time. Hepatitis, pancreatitis, cholecystitis. So basically all in that duct area, all right? Hepatitis, pancreatitis, cholecystitis. And then you can also get some rhabdo with this. And thrombocytopenia would be potential risk as well. So we talked about this a little back when we did our first pharmaco briefing, bringing some nutraceuticals in here, omega-3 fish oil. We do use it, especially for super high hypertriglyceridemia. I use it all the time. It works. If my patients don't take it, their triglyceride levels come in. Dosing is 1 gram. Can give more, but that's kind of the minimal. You have triglyceride issues, we need to get it. Up to 4 grams. I have a patient on 4 grams right now trying to get his triglycerides low. Give with meals. Do not open dissolved capsules. Those preparations may give a little bit more fish burps. That's a lot of what my patients complain about, but it's all in the quality of the fish oil as well as quality of the container. This is the prescription omega-3 ethyl esters, which is called Lovasa. It is very expensive, CYP 450 system, but it is metabolized in the liver, and it's a prodrug converted to an active free drug. We really don't know how it's excreted or its half-life. We really don't know its exact mechanism, but it reduces hepatic triglyceride synthesis. So these are your CAM and alternative therapies, and you will end up recommending some of these. All right, Arjuna is basically a tree bark. Has not shown to necessarily lower cholesterol. Cinnamon, not too much evidence with that as well, but a lot of patients like it. Holy basil, no evidence with that either. Licorice, anise, black licorice, no evidence with that either. Really the only one that has some evidence is the red yeast rice. And what's interesting is that rice is fermented with mold. It's the same active ingredient that is in the statins. What happened was, so the FDA went after the supplements and basically deemed it an illegal medication because they weren't doing any trials, it wasn't approved, and they basically made them take out the active component in the red yeast rice. It's still marketed, it's still said that it's going to help, but most of the active ingredient that actually lowers your cholesterol has been taken out because of the FDA. So tell them to get it from reputable sources, and it's negligible probably now because they do not have that active ingredient in it. The rest of these, coriander, there's no evidence of that. Alfalfa, it does prevent cholesterol absorption in the gut, so you could technically say that may work because it's actually on the absorption in the gut. And then fenugreek has shown to have some assistance with atherosclerosis, the total cholesterol, and the triglycerides, but really evidence-based, and it was previous evidence, was the red yeast rice for your CAM